Okay, everyone, thanks for joining us again. Let's get started in this edition of Innovations in Diabetes and Cardiovascular Health. Reminder not to use any private health information, personal health information in your case discussions or otherwise. Here are our usual reminders about assistance, both from a technical standpoint from Rick and for other matters from Claire and for myself. Just some basic information about cardio, which you've seen before. And today we are going to have a presentation on new developments in the treatment of type 2 diabetes from Kathleen Dungan from Ohio State. We have a couple of really interesting cases from Dr. Harris and Kyle Smith. And I think our discussants are very well prepared to discuss these cases. I think I matched the cases to our discussants quite well this time. So here are the disclosure statements. There are no changes that I'm aware of from last week. And a reminder once again to use person-centered language as to the best of your ability. It does take practice, and I noticed that we have all gotten much better at it. Okay, Kathleen, the floor is yours. Take it away.
Hi, everyone. So I'm going to provide some updates on type 2 diabetes therapies, newer and emerging. And so basically, we're going to focus on some of the newer information with regard to use of GLP-1s and SGLT2 inhibitors. We'll look at some of the future pharmacotherapies just in brief, because there are many, and then talk about Medicaid coverage for these therapies. Okay, so this is actually a revised version of the slide that I had actually presented previously in previous ECHO series. And these are based upon recent changes to both there's an ADA, EASD, which is the European counterpart consensus for treatment of type 2 diabetes, which was published just last fall. And then this is reflected in the 2023 Standards of Care for Diabetes, which is published by the ADA. And so there are some changes here. So first of all, things that has never changed is this is all on a background of lifestyle advice. And that includes diabetes self-management, education, and support. And also assessing the patient where they are, all their social determinants of health, all of their background, motivations, capabilities, and preferences. So with that being said, really the one of the pieces that hasn't changed is first to assess for cardiovascular and renal comorbidities. And so that takes you down to this left side of the branch point here, and then take a look at what those specific comorbidities are, and regardless of their A1C, you should be considering this treatment algorithm. So if they have cardiovascular disease like MI or stroke history or a really high risk, then it's recommended to put the patient on a GLP-1 or an SGLT2 inhibitor that has proven cardiovascular benefit, and we can talk about that. If they have, and that's regardless of the use of metformin. So it means that if they don't need glucose control, then you may not need additional, you may be able to take them off their metformin. If they have heart failure, whether it's heart failure with reduced EF or preserved EF, now it's recommended to start an SGLT2 inhibitor. And if they have chronic kidney disease or proteinuria, previous recommendations were if they had chronic kidney disease plus proteinuria. So now this has been relaxed because of more recent randomized controlled trials. Any real kidney disease, they should be placed on an SGLT2 inhibitor because they've been shown to be renally protective. And then from that point, then you can move on to the other agent, either the GLP-1 or SGLT2 if additional glucose control is needed, whether it's cardiovascular disease, heart failure, or kidney disease. And then if you need additional glucose lowering, then that takes you over to the right side of the field here. And previously there were several different buckets considering, okay, hypoglycemia risk, weight loss, cost. And so they kind of just eliminated all of those because the desire to focus on really the two main factors, again, keeping in mind some of those other person-centered individual specifics that may be important to the individual patients, because in patients with type 2 diabetes, the majority of them do need weight loss. And of course, A1C reduction should be at the forefront. So they redesigned this. And so now we have just two pillars, if you will. One is glucose control, and that would include metformin and other agents as needed, and prioritizing hypoglycemia avoidance in those high-risk patients is still of importance. And then, so you can see here in this table that they've now graded individual classes and therapies within classes, because there are some differences specifically with the GLP-1 class. So those very high efficacy medications are going to include dulaglutide, semaglutide, particularly the injectable higher doses, tirzepatide, which is the new one called Mounjaro, insulin, and then combination approaches. And those that are high efficacy, but maybe not quite as high, are shown in that second row, include most of the older medications, other GLP-1s, SGLT2s, and sulfonylureas. And then more moderate glucose lowering with DPP-4 inhibitors. And then if you go to the second pillar here, which is weight loss, there is, of course, the need for changes in lifestyle, long-term weight management programs, consider weight loss medications, and also consider weight loss surgery, which is in and of itself a very highly effective treatment for type 2 diabetes. But in terms of the medications themselves, the greatest weight loss is observed with the semaglutide, particularly the injectable tirzepatide, and then your other GLP-1s, which include dulaglutide and liraglutide. And then all the other GLP-1s tend to cause less weight loss. So that's why they're on the third row here, along with SGLT2 inhibitors. And then your more weight neutral medications like DPP-4 inhibitors and metformin. Next slide. So if we kind of dig down a little bit more on the GLP-1s, they can be divided into the intermittent activating GLP-1s. So they intermittently activate the GLP-1 receptor, and they tend to have a little bit more in the way of gastrointestinal side effects as a result, but this is all dose dependent. And we really don't use too much of these anymore, except for lixisenatide does come in a combination formulation with glargine. Next. And then these are continuously activating GLP-1s. And because they continuously activate the receptor there, they tend to have greater efficacy. And then over time, most patients get used to, or the nausea goes away. And that's the major, I would say, limiting adverse event with GLP-1s. So it's very important to make sure that they are aware that this could occur, but in most people, not all, it tends to go away. And in terms of cautions, we think about anyone with a history of, or family history of medullary thyroid carcinoma, so those are C-cell tumors, or the MEN2 syndrome, which includes medullary thyroid carcinoma, because that was observed in rats at therapeutic doses. We are not rats, and we have very different C cells. And in fact, we have very few C cells and no GLP-1 receptors on them, as far as we know. Use caution in terms of chronic kidney disease, because it can cause acute kidney injury, particularly if a patient becomes nauseated. Gastroparesis, and there's a question that there could be a possible risk of pancreatitis. This has not been borne out in large randomized studies. Next slide. In terms of SGLT2 inhibitors, these are the 4 that are FDA approved. The first 3, CANA, EMPA, and DAPA, have the best data in terms of cardiovascular and renal protections. Their counterpart, ertugliflozin, we don't know why exactly, but it could have just been by chance, did not, had some heart failure protective properties and reduced albuminuria, but didn't meet its kind of primary major adverse cardiovascular event endpoint. But those are the dosing strategies there. They work by blocking renal glucose reabsorption. And the caution here is by far the most common side effect is urogenital candidiasis. And in randomized trials, they haven't been shown to increase the risk of severe urinary tract infections or anything that requires hospitalization, pyelonephritis. If depending on how you do the study, you can see increased UTIs, but it's hard to really sort this out because they cause polyuria and oftentimes patients can have asymptomatic bacteriuria. And so I think the biggest concern here is just if patients get recurrent candidiasis, I may reduce the dose. I may take them off of it for if they have recurrence and get their glucose levels down, with the theory being that you can, they're more likely to get candidiasis if their A1C is at 10% than if it's down at 8%. So I'll try to use a couple of those strategies to see if we can get patients to tolerate it and not have to discontinue long term. Other concern, occasionally had patients had severe polyuria. And so that's my only other caution is if someone has really high A1Cs, that they should at least know that they could have worsening polyuria, and then think about whether or not you might want to hold off a little bit, get them under control with insulin or whatever else you're going to use. Euglycemic DKA has definitely been observed, so patients should stop the medications ideally 4 days or so before any prolonged NPO status and during any kind of severe illness particularly if they can't take anything by mouth. And there's this question about possible link with amputations with the canagliflozin outcomes study, but it was not observed in any other randomized controlled trial. So it's hard to know if that's a true observation or something that happened by chance. The other really important caveat here is that patients who have chronic kidney disease, while these are renal protective, if the eGFR is low enough, you won't see as much glucose lowering. So it's a gradual effect, and generally, if their eGFR gets below 45, you still can see renal protective effects, but you won't see much in the way of glucose lowering. Next slide. And then tirzepatide is the newest drug that became available just last year. This is Mounjaro. It is a GLP-1/GIP analog, and this is really exciting because it actually kind of blew away, as you can see, semaglutide in this randomized controlled trial in terms of A1C reduction and weight loss. Now, there is no comparison with the 2 milligram dose of semaglutide, so that kind of remains to be seen. And there's also no head-to-head study compared with the highest dose of dulaglutide, but these are very impressive results. And we don't yet have the cardiovascular outcomes trial. That is ongoing, but the early cardiovascular risk markers are promising. So more to come. This is approved for treatment of type 2 diabetes, but not yet approved for weight loss. It should be probably as these clinical trials are completed soon. SGLT2 or GLP-1s, which ones do you use? The SGLT2s should be first line for heart failure and renal patients, but just remembering that their A1C reduction capacity is diminished at those lower eGFRs. So you need to use something else if you also need to lower their A1C. GLP-1s, specifically in patients with atherosclerotic cardiovascular disease and stroke. And I'll show you some data that would suggest that there might be more stroke benefit, although you probably get some benefit with both of these drug classes. And there's probably some renal benefit with GLP-1s as well, just not as dramatic with SGLT2s. And then that greater A1C reduction. And we believe that the weight loss and glycemic benefits otherwise are additive with these two classes of medications. Next. And then here's what I was referring to in terms of the cardiovascular outcomes data. When we look at individual endpoints and try to compare amongst the various studies in a meta-analysis form these classes of medications. You can see similar benefits with 3-point MACE, which includes MI, stroke, and cardiovascular death. You can see that there is benefit possibly with both GLP-1s and SGLT2 inhibitors, but you can see that the magnitude of that benefit favors SGLT2 inhibitors. For stroke, again, you can kind of see that there's this somewhat of a difference here amongst the different classes. The GLP-1s tend to be more favored in terms of stroke. SGLT2 inhibitors and GLP-1s probably similar in terms of cardiovascular death, and then the renal outcomes, they're different there. Now this is a little bit older meta-analysis, but I don't think any of the more recent cardiovascular outcomes trials will change this outcome much. Next. So then looking at future therapies, these are really exciting advances that we're seeing even in phase 3 trials. So for example, once weekly basal insulin is being studied, and it's thus far been shown to be very safe. This is in the clinical trials environment though. So, and it's safe because it's an ultra long acting, and you're kind of providing that baseline, and overall it's it has the potential to be combined with a once weekly GLP-1, and then you can reduce the number of injections that a patient might have to take theoretically to just once a week. There are clinical trials looking at glucose responsive insulin. So this means that an insulin that only lowers your glucose, or is only active when your glucose levels are elevated. And this is similar to how incretins, like GLP-1 based therapies, work. They stimulate insulin secretion from the pancreas without causing any hypoglycemia. And then there are many drugs now under development that are taking advantage of the multiple different incretins and their complex interplay. So along the same lines of tirzepatide. And in fact, these involve multiple different targets as shown here, including glucagon and the glucagon receptor. And these are also attempting to recapitulate some of the changes that we see following gastric bypass surgery, where we see this really complex hormonal milieu that ultimately leads to weight loss. And then there are a number of other approaches. None of them are near FDA approval yet, but many of them are in phase 2 or in phase 3 studies. Next slide. And then in terms of approaches, I think we, in the diabetes world, would like to see a lot of more precision type of medicine that we currently see in the cancer therapeutic space. And so that's certainly a lot of that approach can be applied to diabetes. In particular, there's a lot of heterogeneity and subtypes among adults with diabetes, including a lot of overlap with type 1 diabetes. And that really is important because it predicts the response to therapy and risk for complications. And so more to come on that. There's actual emphasis from the ADA and special programs to flesh this out some more. And then in terms of the overall strategy, one of the more recent shifts in the ADA guidelines over the last couple of years is really emphasizing the need for early combination therapy. And that's at the time of treatment initiation. And partly because there have been a few studies now that demonstrate that you get those patients under control early, then they are more likely to stay under control. And there's also evidence now from more than one study that early combination therapy will extend the time to treatment failure. And so, diabetes is a chronic disease. And so we want to always be thinking about not just what the present is, but also the future. And then, as you heard last week, we now have not just continuous glucose monitors, but many other types of connected devices that have become available that help patients and help you understand how much patients are taking of their medications, when they're taking them, and help them to adjust their therapies. So next slide. And then this is a description of the Ohio Medicaid's preferred formulary for type 2, well, for all diabetes, really. And about a year ago, there were a lot of changes. All of the step therapies were removed for all of these medications except for Degludec, which is Tresiba, which still requires step therapy. But in my opinion, Glargine U300 or Toujeo is very similar to Degludec. So if you're thinking you need an ultra long acting basal insulin that doesn't cause much hypoglycemia, then you can always use Glargine U300 and you don't need a PA for that. Continuous glucose monitors also covered without any prior authorization, which is really, really amazing. So, and then here are the GLP-1s and the SGLT2 inhibitors that are currently on formulary. So you have a nice choice there. And based on the guidelines for the GLP-1s, you would go with the dulaglutide as being the most effective and with the greatest weight loss. Next. And thank you, and I welcome any questions.
Thanks, Kathleen, for that really nice overview. Any questions for her before we move on? I think there was a comment in Kathleen in the, yeah, what's the definition of treatment failure?
It's not consistent in all of the studies, but in general, it's an A1C in the GRADE trial, which was just reported by the NIH last fall. It was an A1C persistently over 7. It had to be repeated and consistently over 7 after they've already, been put on treatment and reached goal. And in this case, all of the patients their A1C goal was less than 7.
Thank you. Any additional questions? Okay, if not,
I have one question regarding the SGLT2 inhibitor class and the risk for, say, for example, 48 gangrene and I guess amputations essentially that are hastened by its use. Is there any way of like risk stratifying patients who may be at risk for those particular outcomes compared to others? I came across something in like the continual CME that, we have to do every quarter, saying that like, they only really increase the I want to say the relative risk by like 3-fold, which again, that's big, but granted, diabetics are already at risk anyway, and so with that being said, how do you kind of determine who may actually not benefit per se?
Yeah, for amputations, it's really there's very, very little evidence. It was in the Canvas trial where this was observed, which was a single, albeit very large, randomized controlled trial, and it wasn't observed in any of the other cardiovascular, outcomes trials, and that was amputation. And so it's really hard to say that it actually is a real thing. Now, in an abundance of caution, if someone has an active foot ulcer with really bad peripheral vascular disease, I'd probably wait at least until it's treated and, that there's nothing unstable there. In terms of the necrotizing soft tissue infections, the evidence is even more weak. It was never seen in any single, and these are tens of thousands of patients. There was no signal whatsoever. And so it's something that has been reported to the FDA in case reports, and there were maybe 1 or 2 epidemiologic studies where the signal was seen. So it's really hard to say. Now, all the same, if I have somebody who's had a history of a severe necrotizing soft tissue infection, I just won't, I won't use them because it is something that's being monitored by the FDA. So it's really, and you're right. any patient with type 2 diabetes is at risk, and patients with obesity, not even just diabetes, but one of the biggest risk factors is any previous kind of surgical or procedural intervention. So there's really not a great way to identify people at risk of it. And part of it's just so rare.
Okay, thank you. Two fantastic cases this morning. I'm going to turn things back to Claire for just a moment.
Sure. So just a reminder that you can log in to watch the recordings of previous clinics or today's clinic if you want to. Cardio is having another webinar on February 22nd. It is pretty related to today's topic, I think. If you are interested in signing up yourself or sharing with your networks, I will say I looked at the registration data yesterday and I did recognize some of your names on there. So that's great. If you would like some sort of flyer, it's on our website. Otherwise, we hope to see some of you guys there. Next slide, Rick, please. As a reminder, your post-clinic survey should be in your inbox. If you could give us some feedback on today's presentation, we would appreciate it. And then just another reminder to either submit your initial 2 cases, or if you're interested in submitting another one, we are still short on cases. So let me know if you'd like to present another one. We would gladly welcome it. Otherwise, we will see everyone next week.
Okay, thanks everyone. Have a wonderful week. Bye-bye.